Hi, everybody. It's Kevin and Donna. We were backstage just catching up on life, seeing what's going
Mhm.
on, and really talking about like interesting decisions in life you have to make for different balances and different things you're trying to do. And we're going to talk about making some decisions and using a really neat website and a couple different folks that are helping produce that website on how they're doing choosing wisely. So stay tuned. Right after the reel, we'll jump into it and we'll talk about all the elements that you need to know as a pharmacist and part of the pharmacy world to choose wisely for your patients.
Mhm.
So, speaking of choosing wisely, we're doing this episode, and you can hear a slight hum potentially in the background. That is a tamper trying to get ready to put in some concrete at Kevin's house. But I wanted to switch over to Donna to say just hello and so excited to see her. You
Yeah.
guys are on the Deprescribing show right now. Please join our PH Ally and make sure you're getting Med Strong by grabbing Donna's book. If you're an RPH Ally member, you get a special discount too. So even better. But Donna, choosing wisely.
Absolutely.
How did you run across it? When did you run across it first?
Oh gosh, choosing wisely. I don't even remember when I first saw it. I've known about it for so long. um, but it's just been such a great website. I want to say it was probably around like 2000. Well, it started out around 2012. So it was kind of new with the adoption of it. But the American Geriatric Society actually has a list in there. And that's the one that really caught my eye. They have so many great tools for folks to use and for practitioners to use. And many of their items for the American Geriatric Society is written in just various patient friendly pamphlets too. So I really liked their style and what they do and their practicality. So when thinking about choosing wisely, and gosh, yeah, this makes total sense, right? Let's only do what we need to do and not overdo. I think that that's really important that we understand that. So when we're thinking about older adults, are you going to be as aggressive necessarily as you are with maybe younger people with various items, or we're going to think a little differently about safety. We've talked about the pharmacokinetics and pharmacodynamics previously, Kevin, in much earlier sequences of in sessions of these programs that we've been doing. So with that, we know that the bodies change, that as we age, the absorption, distribution, metabolism, elimination is very different, but also the ability for medications to cross the blood brain barrier, and also how sensitive older adults are to cardiovascular side effects and anticholinergic side effects. So when you're looking at these, you can really look at what AGS has put together for their choosing wisely. And typically, these groups have 10 different things that they want folks to think about and look into. So, before we like really jump in, there's one in particular that I would really love to bring to everyone's attention. But so, what is choosing wisely in general? Choosing wisely actually has over 70 different associations that have lists of 10 things to avoid, to be careful of, depending upon what it is, whether it be surgery or older adults or some type of ear, nose, and throat, for example, whatever the society is, they have their 10 that they look into. So you can go into choosing wisely and actually look at all the specialty society partners that they're with. But with that said, why are they doing this? What's the point of it? What's their mission? And the mission is really to be thinking about better communications. And this is what I love to talk about, is how we better communicate, how we teach patients to better communicate with their providers, how we as pharmacists might better communicate with providers and with patients, so that we can only be taking medications that are necessary and eliminate those that are unnecessary or inappropriate. But they're also looking at other things, various treatments, or whether you would do surgery or not, various things such as that. But a lot of these do have some type of medication associated with them. So when we're looking at the AGS, if we go down to number 9 on this, and I just think this is just so important to be thinking about. And I've used this in many programs that I've given to providers when I've done CMEs. And what it says is don't prescribe a medication without conducting a drug regimen review. Makes sense, right? We want to make certain that someone really has a new problem and not an existing problem that they're already being treated for, but not successfully, or maybe they're having side effects to some type of medication that's causing this new issue. So, thinking about that first, but I always switch this around, Kevin. I always put a twist in it. And instead of saying, don't prescribe a medication without conducting a drug regimen review, I say, don't continue to prescribe a medication unless you do a drug regimen review, right? Doesn't that make sense? Like, why are we continuing some of the meds that we are 10, 20, 30 years down the road? So let's think about that. Don't prescribe, but also don't continue to prescribe. And I think that that's a really important factor to be thinking about.
I think it's fantastic. I mean, I feel like that is one of the biggest problems about choosing wisely is not thinking you have a choice, right? I mean, you put the drug on board and then you think, well, that after it goes on board, then it never comes off, or the specialist put it there. So I'm never going to consider it or look at it or change it ever again. And the fact that
Right.
you've changed that from prescribing to continuing or escalating therapy or adapting, whatever the case may be, having a full medication review prior to those decisions happening, which includes continuing, is so massive and can run us into so many problems. So that's perfect. When you were talking, Donna, earlier about like the
Mhm,
entire point of choosing wisely and looking at all these different great institutions and
mhm.
groups that are contributing to it, when they're trying to do their spin, Donna, like when they're
Yeah.
giving their twist or their kind of points that they're bulleting out, how
Mhm.
do they go about that? Like, what do you see in a typical, like, if we pull up anybody, I know we're going to look at AGS and we're going to look at ASDP here soon.
Yeah.
What are they usually detailing out? Is it kind of a random list of 10 or are you seeing some themes?
No, I mean, there's definitely themes that there are for older adults, for example. So when you're looking through this one, I was going to actually show some comparisons between the AGS and ASCP. But when we're looking at medications and not over prescribing, basically, and that's really a theme throughout these is what are you using to help the patient, and try not to overprescribe or try not to prescribe unnecessarily. Other things that we're looking at is, thinking about the uh, like we talked about this already, the J curves, right? Like what changes in targets might we have for different populations? So it might be talking about specialty populations or something that's going on with individuals with a certain disease state, with a certain age group. So other comorbidities that we might want to be thinking about. So some of that is also in there. They talk about you know, uh, treatment for um, say acute issues, and are you going to treat or not type thing. There's one that I can't wait to get a guest in for in the AGS. It says don't use antimicrobials to treat bacteremia in older adults unless specific urinary tract symptoms are present. So if you're testing and symptoms aren't present and you're seeing that there's a UTI, you're not going to treat. You want to treat if there's symptoms. And I can't wait to have a special guest on to talk more about that, who is a specialist in infectious disease. So those are some of the things that we're thinking about too. So some of it is specialty, but I think we have a knee-jerk reaction to take care of something. And that's kind of the theme is you might not have to take care of that. It might resolve without you having to do something.
That makes perfect sense. Yeah. So I was interestingly, you could see my Google Drive on the background, but I was trying to do a side by side comparison of the two together, and you can see like looking at them, Donna, and just kind of reading through what's currently available. In
Mhm.
terms of updating, like when these associations are updating what they're providing to
Mhm.
choosing wisely, is that something that's happening every other year, every year? When are you getting these new updates to come through?
Yeah, so it's supposed to be done yearly, and I know that, for example, being a member of ASCP, they do their yearly updates on their list during their annual meeting. So I do believe that other associations are probably following the same suit as to how it's being done in ASCP.
Got it. No, that makes perfect sense. And then what you were saying previously about the urinary tract infections, I can't tell you how many meetings I was a part of with the long term care slash swing bed slash hospital settings of doing that exact same
Mhm.
thing. And the number of transfers from a long term care center to be institutionalized for a UTI non symptomatic,
Yeah,
that just added so
right.
much headache to the system, so much burden on the individual.
Yeah.
The
Yeah.
likelihood that we're going to blame everything on the UTI rather than digging a little bit deeper to find out what else could be going on. That's an often thing. We want to find causation, so quickly that we
Exactly.
for others.
Exactly. Yeah.
And so on here, Donna, we looked at number 9 for
Mhm.
AGS. Did you
Yeah.
want me to bring the ASCP list next, or where are we heading? Because I
Um,
think with
yeah.
Wisely, we go, each one of these
I
is
know,
great.
you can go so many different places, but I wanted to highlight ASCP because, um, they're kind of a newer list, if you will. They only, started, I wanna say, a few years ago, in adding a list, so some of it is, it's not that all of these have been in place for years and years. Some societies are adding in now, so there's there's always, I think, going to continue to be new ideas and new groups adding into choosing wisely. But I wanted to go over some of them. So again, there's 10 of them, but of course that would take some time. So I really want to do, I would love just to start with number one on this list. And it it kind of bridges over as to what we were just talking about, to not initiate a medication or treat some new emerging symptoms without first ascertaining that the new symptom is not an adverse drug event um, of an already prescribed drug. So, in other words, don't do prescribing cascades. Let's get a handle on this and let's see what's really happening. Can we switch a drug? Can we adjust a drug if therapy is still necessary? Or is the therapy even necessary at this point? Um, so, talking about prescribing cascades, I coined a phrase yesterday, Kevin. I was so proud of myself. So, I actually put it out on Twitter. I was commenting on someone's information about prescribing cascades and how like anticholinergics are really an issue for falls and frailty. And so I went in there and I said, you know what? This whole in polypharmacy too. And I said, polypharmacy, if you're reducing that, you're probably reducing some anticholinergic burden, and then you're probably reducing some frailty issues, and then you're improving quality of life. And I said, that's a deprescribing cascade worth trying, right? We can do positive
But
stuff. Deprescribing cascades. I love it.
yeah,
So let's get
I
away
love
from
it.
the prescribing cascades. Let's do the deprescribing cascades instead. So I was
It's
very
funny,
proud of
like
that.
the letters being peeled back, Donna, with a deprescribing casket is fantastic. I think that here's a curious question for you. Where should this
Mhm.
happen, Donna? Like in your mind, like wait, maybe the question you would ask back to me is where shouldn't it happen, Kevin? But when it comes to not going through the deprescribing cascade, or going through not going through now you're throwing me off, not going through the prescribing cascade and deprescribing instead,
Mhm.
where in the initiation or the continuation of therapy do you feel like there is an ideal scenario for this to occur? Because I think that is a major question in healthcare right now that we are struggling with. It's not that we don't know this needs to happen. It's
Right.
where, who's
True.
responsible, who's going to
Yeah,
do this.
absolutely. And, I'm gonna make it hard, Kevin. Every encounter, everywhere the patient is, it every healthcare encounter, whether they're at the primary care, the specialist, the pharmacy, the physical therapy, who's ever suggesting or seeing something new, it should be questioned. No doubt about it. Um, it's just so important to do that. I was talking to a physical therapy group last week, and teaching them about anticholinergic burden and frailty scores and the polypharmacy. I'm like, put numbers to it. And they were so excited. I said, people, you probably have people in, they're telling me they're in so many meds. And I said, they're not going to be successful with their physical therapy to the point you're hoping for them to be, because the medications are inhibiting it from happening. They're only going to get to a certain point. They're not going to all of a sudden not be dizzy anymore or not be, be able to be balanced if if they're on medications that are causing these things. So we talked about that and they were so excited to, but how do we do this? Are we supposed to approach a doctor? Are we supposed to talk to the patients? I'm like, every encounter it should be a conversation about, do you need all these meds? And talk to a pharmacist, talk to your doctor, whatever it is, just get it going, get the conversation going.
I was talking with with Jaron and with Chad and with Jen. I mean, all these incredible pharmacists we have, and Donna and Delon and so many others that are really trying to push for how do we gather the right data? How do we make sure this is happening? The one interesting thing, Donna, is I feel like the seat isn't even at the table on who I feel like should be doing this, right? I feel like oftentimes like we have a certain cadence of here's how an individual is seen, here's how they're identified as having an issue, here's how it's prescribed, here's how it's dispensed. And that's the way we're operating medicine. And some things that are being pointed out on very well vetted websites through large national organizations, there is not a point for them to really address this. And I think that is some of the work that you're doing through privately doing or grant-based, kind of funding related to the business models of having, I know folks don't like the word clinical pharmacist, but having an evaluative pharmacist that is looking at individual details of therapy to be able to break this down on a regular basis, and going to the same long-term care cadence or not on a monthly, quarterly, biannual type setting.
Yeah,
I think we desperately need it, Donna. I mean,
we
I think
do.
it is high
We
time
do.
someone recognizes like we're literally harming people out there by not affording this to be in
Yeah.
place. And
Yeah.
literally we have government run organizations putting these detailed components together and not acting upon them. So I think we have a little bit of work to do with saying, look at all the value, that is there from people to deprescribe and to hit that deprescribing cascade.
But why are
Soapbox.
we still talking about our value? I have to say, it was really exciting, though, to see the owner of this clinical group, of this physical therapy group, being very clinical and wanting, he's like, we should have this all under one roof. And I'm like, uh-huh, yes, we should. So, so the conversations are going, and we've got to make this happen for sure.
Oh, we do. And that's the nice thing. They are going, and I love that we can keep each other involved on here's what's being done, here's how you can participate. I think those are the next real steps behind
Yeah.
it.
Yes.
The next one on ASCP's list, I don't know, Don, if you wanted to
Yeah,
look at it.
number 2. Yep, we wanna look at number 2. And, don't continue a medication at transitions of care without a pharmacist or other qualified healthcare professional performing comprehensive medication reviews to, look for accuracy and appropriateness, etcetera. Love this one, right? Here we
This one,
are. Here we are. Every
thank you,
transitions of care.
yes.
So, anytime there's a new med, really is a transition of care. You can go to the doctor's office, ambulatory, go back home. But if you have a new medicine, guess what? That's a transition of care right there. So, so yeah, but also in the bigger picture too, hospital to home,
Sure.
hospital to rehab home, whichever combination you want to look at,
Right.
totally needs to be addressed.
Yeah, I think that at least for me, like personally, and I know all the folks listening in, they've seen it within their own family. These kind of,
Mm,
and they're not necessarily mistakes. Like it's not about blaming folks.
yeah,
It is missed. In
yeah,
general, we have things that are helping people inside of one setting, and we're not looking
mhm,
at a global picture. And then we hope that they work somewhere else. I mean, it's really similar to saying,
right.
Savannah and I want to start a garden, and
Mhm.
I want to put carrots here, but Savannah wanted to put tomatoes. And so I'm digging up the carrots and she's digging up the tomatoes, and we're not working in sync. And I think
Yeah,
there's a ton of issue with this transitional care component that really does hit home. And I love that you call out, it is not just hospital to home, even though that is extremely important. It is
Mhm.
every new medication put on board. We need to be able to
Yeah,
evaluate the entire picture.
yeah, absolutely. So Kevin, another thing, and this kind of like is just in my head about, I don't know, like I'm sure with your kids or whatever, people are, going to the doctors for your own health, for your child's health, whatever. And so what are the doctor's offices doing now is, oh, go into this portal, sign in, pre-register for your appointment kind of thing. Can you imagine if we did that for the pharmacy? Like, I don't get what we're doing. I don't understand how they want people to fulfill the portal. And I'm getting scared about that and nervous about that. And we're relying more on patients versus less on the system. And it really hit me today because I was asked to do something for my mom, and I was just like, whoa, wait a minute, time out. Is that the next thing? Are they going to say, oh, just put your prescription in, and we'll make certain it gets done? Like, I know that there's electronic prescriptions, don't get me wrong, but
Sure.
it's like the patients, I don't know, I'm just kind of bothered about it. And I
I,
guess we'll do that when we put in the numbers for refills too.
oh, it is. And I think there's a lot of measures that were and metrics that are put out there that were well intended. Like they wanted to help people be more informed with their care, right? And
Mhm.
that's great. But it ends up being utilized to be able to help the system churn more individuals through it. And
Yes.
so to do so, you take off burden from your own staffing and you push it on to patients.
Yeah.
That's what the patients are not doing well. Like they're not feeling taken care of. They are not connecting the
Mhm.
dots. They're not seeing the overall value. And so by putting more burden onto their shoulders, we're not benefiting them,
Right.
giving them more to look at. It's
Yeah.
like if I went in, I don't know what's a good, there's a ton of subjects I know nothing about, but if someone was going to tell me like this is how you would, compose like this piece. So like your daughter, for example,
Mhm.
would be able to tell me like, okay, Kevin, here's the way they would think about putting notes together. This is the way they
Mhm.
would put, like an ensemble together. This is the way they perform. I think it was really interesting, but I would not want to do it myself after
Right.
having her describe it to me. Right. And so I
Yeah.
feel like that oftentimes, Donna, is what we ask. Like we're saying,
Yeah.
here, individual that has never played music before, can you write a symphony, for us? And
Yeah.
conduct it
Yeah.
yourself. And I think it is a ton of pressure that we don't realize. You can't squeeze more juice out of the system. You need to make sure that folks are getting hands being held and walking
Right.
the entire process.
Right. And when they go home, what are they expected to do too, through these transitions? So I just think we rely a lot on our patients, and they're just trying their best, but don't know. So
Yes,
I wanted to move on to number 7 next. No, we're jumping up a bit.
perfect.
But, I think it's super important, and we talked about, why are some things important, especially for older adults, and this talks about the central nervous system and, really the potency of medications on the central nervous system, and then if we're combining more than, just 1 or 2 items that might have a central nervous system or CNS effect. So when we're looking at this, and I love what they actually put in here, they're talking about antidepressants, benzodiazepines, Z drugs, opioids, um, gabapentinoids, antipsychotics, and antiepileptics. So they're talking about all of these medications, types of medicines that have a CNS activity of sorts.
Yep.
And is saying, "Don't use 3 or more." I'm going, "Can we just only use 1 if we only have to?" Like, but still, like, yes, people may need more than 1 of these for various purposes, but
Sure.
we gotta be careful. The list, these long lists that we talk about, the polypharmacy lists, believe me, people are on 3 antidepressants slash anti-anxiety meds, and that's not even talking about the pain relief that they have going on too. It is so incredible what I see. So I just think that this is so important, and I just think that we've really got to start counting just basic numbers. How many meds? How many are central nervous acting? Um, like that is telling in itself. My students now, when they do their patient reviews. They give me a polypharmacy number, they give me an anticholinergic burden number, and they give me a frailty score. And we talked about it this past week because they were doing their presentations, a formal presentation to um, some newer pharmacy students.
Yeah.
And I said, what do you think about this? Like when you're giving your presentation out and putting these numbers, what do you think the impact is? And we're talking about how important it is to put numbers to things. So even just this simple exercise of no more than 3, you'll probably see people on 7 or more. And you have to go, whoa, wait a minute, what are we doing here? So I just think that these very simple numbers can speak volumes.
Uh, I mean, I think you're not giving yourself enough credit with saying simple. It's profound to have comparative analysis. Like you can't have something comparative if you have a list of words. You can't have something comparative if you break them down and make them numbers. And it's very easy to look at one patient versus the next of this one's a 7, this one's a 1, to be able to have some at least triaging process and then some heightened level of kind of clinical application. And I think that's brilliant, Donna, for folks to be able to do inside of their individual institutions. When you have your students do that, has that been implemented inside of your electronic health record, or is that being done paper form when they're breaking down someone's chart?
Yeah, so where it's not in the Epic system, there is some the actual scores are not there.
Yeah.
But when I am writing recommendations and we need to, state why we're making a change or why we're suggesting a change, that's when I use it. Polypharmacy of this, anticholinergic burden this, frailty score. Can we make this better? And I'll use that to help educate why a change is so necessary. So it is being used, but it's just not necessarily patient per patient yet. I do know some folks I've done some programs for, and I know that one group actually put it in their system, anticholinergic burden, and I
Smart.
know another group was interested in implementing it as well. So people
Awesome.
are finding ways to do this.
I love it. I love it. No, that's so important. I am surprised by the 3 or more. Like that's a little, it's a little massive.
So the next one I want to do is 8.
Okay.
And 8 is don't combine opioids with benzodiazepines or gabapentinoids. Love this one,
Mhm.
especially to treat pain in older adults. We have to just constantly be reevaluating. Really important. A couple of things that um, are striking with this is one, if they're even combined together. I'm just like, gosh, please no. Throw in a muscle relaxant too, and forget it. Um, so with this, and we see it, right? And then they're having respiratory depression. No kidding. No kidding. So we've really got to make some changes here. If gabapentin is actually dosed 900 milligrams or more per day,
Mhm.
it has a profound effect on opioid um, um, addiction that occurs. It actually they actually know that there's this like level of gabapentin that actually increases the risk.
Wow.
So we are running into these issues, and what we're doing even at the hospital is making certain that if both are needed, say there's which I believe it's um, just even those two, just a opioid and gabapentin, not just a, if there are those two.
Yep.
Um, we're calculating to make certain the milligram strength of gabapentin and making certain that we're below 900 in making those recommendations. So super careful and really like if you're on one and the other, do you really need both? Do you need both types of pain to be, um, treated, or is one actually working and the other one you thought was going to work but it really isn't, so we've added on something else? So we have to be thinking about the types of pain that people are experiencing and what we're using for that.
That's what I was just going to ask you about pain theory, like
Yeah.
nerve versus somatic. If you have
Yep.
someone with lower back pain and they also have a nervous pain related to their diabetes. So if they have a polyneuropathy, right?
Yeah.
When you're coming to those individual patients, you're saying that yes, that happens. Like we see that combination quite often.
Mhm.
But when you're getting that combination, your goals are not only trying to reduce their opiate levels down, but also find alternative therapies to help with their pain. And
Mhm.
two, keeping that gabapentin number below 900 to treat their nerve pain. And then
Mhm.
if you're having to go further, Donna, now you're looking to an alternative therapy using lidocaine or some other modality.
Yeah, yeah. So so for me, I think patients don't always, so they might come in with gabapentin, for example, or both. And if they're still in pain and they're saying their pain isn't resolved,
Right.
they're not getting an effect from the
Right.
medicine. So yes, we have to start looking at alternatives. And sometimes we are suggesting, like you're saying, the lidocaine patches, but also just heat therapy, or the non-farm type things. There's information out there too on music therapy and how
Yep.
that's helpful for pain as well. Changing the mind of what you're feeling can be very different for folks. So in are you doing that in the hospital? Probably not, but in transitions of care, you certainly could um, do that in a rehab setting more so, and even at home. That, of course, can be used very effectively. So,
Love it.
yes, and just we have to reevaluate, right? We have to reevaluate what's going on with the patient. Um,
That makes
and
so
then
much
it
sense.
goes the other way too, Kevin. People might not be in pain, but they're still taking the medicine. Post surgically, they're still on both, or they're on gabapentin, have a surgery to take care of that nerve pain, but
Mhm.
post surgery they're actually on the opioid too, and then they both continue on, but they're not having pain, so that's good. So just keep doing what you're doing. Not appropriate. So it's both ways of looking at it for sure.
Oh yeah, I love the call out for lifestyle medicine to be able to pull that in and go what supplements, what deficiencies could be at play here with, I mean, metformin, vitamin B12, lots of other issues that could be at play that are unrelated to a certain disease state or just exercise, in general, like you were saying,
Absolutely.
music
Yeah.
therapy. Um, the other piece you bring up though, Donna, I think is so important. Just highlight one more time. You were saying the other problem is someone has it, it is on board, they don't have pain anymore, so they think it's necessary for them to go and pick up at the pharmacy every single month. How do you help people avoid that, Donna? Because that's a very real issue that someone goes, I can't get off that because before I was off that, I was in incredible pain.
Hmm. Yep. I ask the question, do you still have pain? And if they go no, I'll be
Yep.
like, well, have you ever tried to reduce it since you haven't had pain? And they're like, oh, no, I just figured it was taking care of it. I'm like, you might not have pain anymore. So we should start trying to reduce it. We need
Yeah.
to start coming up with a plan.
Mhm.
Um, and there's one in particular, a case study which I absolutely love. It's by Michael Steinman, and it's There's Got to Be a Happy Medium. It's an old case, and I
Yeah.
actually met Michael Steinman, and I told him that I still have the students read this case because it's so necessary still and so vital to helping reduce medicines. But one of the things is about pain being taken care of, post surgery, and but yet the patient's still on the pain medication. And when finally evaluated, like they didn't have pain, but the caregiver didn't want to stop it either, because of course a caregiver doesn't want the one that their loved ones to be in pain, so they're not going to initiate it. So it
Yes.
really is just so encompassing. But I've had cases where I've talked to people and they're like, their mind isn't there. They've been on this since the surgery. One in particular, tramadol. And it's like, try to get them off of it. Try Tylenol if there's some pain, see if that's helpful. And let's try to wean off of this other. And you call back in a couple of weeks and they're like, they're doing great. Their cognition is back. You know, they're back to their old selves. And they were just on the tramadol for too long.
I mean, honestly, Donna, like the way that I've always looked at this is that the best way to avoid it is in the beginning to start with the question, like to always be able to say, do you have pain? And please evaluate. pain for the patient as we continue to progress. And then
Mhm.
everybody's mindset is always shifted toward, you're not going to need this forever, or we're hoping you won't need this forever. So let's keep monitoring it so we can pull you off, and have that kind of deprescribing mindset, as you're saying
Mhm.
before, early
Yeah.
on. And so we don't run into this issue, because it gets to be such a psychosocial like kind of element later on, that it's like a necessary part of life for individuals, and it becomes
Right.
more difficult to titrate someone off
Right.
than if you start the conversation early with this being something that is not a lifelong med to be on board.
Right. The and that's the whole thing too is like you're saying, just to ask the questions. But I think and is I'm not even talking addiction. I'm just people are attached to their medicines in
Oh,
things that are very real, like pain, sleep, anxiety, things you really feel. And we've talked about this before too, Kevin. Those are really hard to win people over to reduce their medicines. So if they've been on it for a real long period of time and they think, oh, it must be helping, I don't have pain anymore, they're going to think, oh, this pain's going to come back if I stop it. So being thoughtful about that and compassionate, sympathetic with the
oh,
patients too, and helping them see like we can just try it. It doesn't mean you don't have to not have it,
yeah.
but let's try.
That's perfect. And you're right. It doesn't even have to be related to pain. Like literally, someone can say, my PPI has saved my life and quality
Yeah,
of life. And that
yeah,
makes it more difficult to pull that off.
yeah.
Are we on number 9 here, Donna?
Yeah, and then the last one's number 9. And I'm talking about pain again, right? So, tramadol. Don't prescribe tramadol for older adults without due consideration of the potential risks and harms to serotonergic excess, thinking about seizures and falls and drug-drug interactions. So, again, thinking about what other medicines they're on that might, cause increased serotonin as well, the antidepressants, SSRIs, SNRIs, for example. But we have to be very careful about this whole thing with seizures and falls. And I can tell you, just this past week, one of my students came and we reviewed a patient, and sure enough, tramadol was started a week ago. The patient fell and they're in the hospital now. But the funny thing, or not so funny, is the etiology of the actual fall was not determined. We're like, it's the tramadol. They just started it a week ago. we don't have a problem saying that. It's looking around and looking back and saying, it's the one of many things, right? It's that added risk that finally tips over that whole tower of blocks of risk that have occurred over a lifetime with a patient.
No, absolutely. That's a great one to end on, because that's the entire issue, is just that one extra therapy that you think
Yep,
is going to help without it being
yep,
monitored, evaluated, and thoroughly reviewed
yeah.
can be the one that leads someone to a hospitalization,
Mhm.
very
For sure.
unnecessarily. And tramadol is an interesting drug in lots of ways, from the pharmacogenomic implications of tramadol to the way that it's broken down, in pro-drug kind of mentalities in both
Mhm.
pediatric and geriatric kind of standpoint. So good drug that I feel like a lot of people were shifting over to as quickly as possible,
Yes.
Donna, because they didn't feel like it
Yep.
was part of that opiate circle.
I
And then
know.
they didn't realize, it
Yeah.
is also a drug with lots of other implications, and
Absolutely.
serotonin wasn't involved with your other opiate analgesics. This
Yeah.
one does have those issues.
It does. It does. So, and then just the other thing I want to, highlight here in general is if we are making changes or, someone's making a change to quote unquote a different alternative for a patient,
Yeah,
we really have to be vigilant for that because not all changes are appropriate either. So we need to be continuing to educate on that as well. So always be looking at these lists and thinking about, if there is a change that's being made, is it a safe change for somebody? Like you're saying, the tramadol, if someone's being switched, is that really safe? It may not be. So need to be careful.
fantastic. No, I absolutely love it. Well, Donna, wonderful episode like always. You and I could go on so much more time. I was looking through some of these, like the next ones, the DOACs, and I was like, oh man, there's so many interesting
Right.
things
I
to talk about.
know. I
But
know.
for just a good time, one other thing I wanted everybody to note on here, Donna is being featured by Drug Topics on the RPH Cast here soon, podcast of putting a few of Donna's episodes together. So if you want to be able to tune into those, They're going to be available for you there. You can also find Donna on the Deprescribing channel inside of our PH Ally, and you can join us inside of it. You'll notice that this episode isn't available anywhere else. It is just inside of Donna's channel. So if you want to get more of it, head on in. That's where they're going to be from here on out. Donna, any closing words?
Just let's keep talking. Let's keep the conversation going. Deprescribe to optimize.
Love it. Have a good night, everybody.
Thanks, Kevin.